Progress.
All right. Welcome everybody again to another session of the Australian Neonatal Webinars. It's a great pleasure to introduce Cara Slagle. She's a neonatologist and a nephrologist, originally trained in Cincinnati Children's Hospital in Ohio, and now moved apparently next door to the Riley Children's Hospital in Indiana. She has done a lot of academic work for the Neonatal Kidney Collaborative and wrote wonderful papers about kidney effects, particularly from a neonatal point of view. And today she's going to talk about renal replacement therapies. And we're just chatting about it, but in my training, I don't think I've ever seen it as a neonatologist, because by the time the kid needed renal replacement therapy, we had to replace the kid to the PICU, and we were never sort of part of that sort of experience. But I hope to hear and learn a lot about the progress in renal replacement therapy today. Over to you, Cara.
Absolutely. Thank you guys so much for inviting me to speak. So like you introduced, I'm Cara Slagle. I'm a neonatologist at Riley Hospital for Children in Indiana, which is that red filled in state there in the middle of the United States. And I'm also an associate professor at IU School of Medicine, but did my training and was faculty on at Cincinnati Children's and was the first neonatology co-director of the Center for Acute Care Nephrology there. So got a really good exposure to acute care nephrology, which really helped breed who I am today. So from an objective standpoint, we'll cover what are some options for renal replacement therapy. I'll cover peritoneal dialysis and continuous renal replacement therapy. I really won't go much into intermittent hemodialysis, but know that that is an option out there. We'll discuss a little bit about what the role of the neonatologist can look like, which is very center-to-center dependent. You should know that I do not prescribe PD or CRRT, but I do know a lot about it. However, if you have very specific questions related to prescriptions and writing a prescription, I recommend saving those questions for Dr. Askenazi and Dr. Selesky, who will speak later in this series. And then I hope to kind of teach you a little bit about how you can advocate for your patient, both if you have a device or getting a device, or maybe know of a center that provides that therapy. And then from a disclosure standpoint, I am a consultant for Mozark Medical, who does make the Carpediem device. And I always like to say I'm an early adopter. So I tend to be one who reads the papers and is like, let's go try this, rather than someone who waits for the evidence to come out. When it comes to talking about CRRT, or honestly neonatal nephrology, in any lecture I do, I really like to talk about the history, because I think perspective is really important. So this is a little bit more focused towards the US. However, it has a worldly application. So the incubator was actually first invented in Russia in the 19th century. It came to the US to show off preterm infants. And that was kind of a circus sideshow. So neonatology actually started as a circus sideshow. Still feels that way some days. But it started in the late 19th century. In the 1930s to 1940s, there was this transition from the practice of birth in the home to actually into the hospital. And newborn health and well-being was mostly driven by obstetricians. It wasn't until 1948 that the first edition of the booklet Standards and Recommendations for Hospital Care of Newborn Infants was published by the Committee on the Fetus and Newborn, and that American Academy of Pediatrics was driving a lot of that. In 1960, the term neonatology was actually coined, and this was the decade that we really began to understand the difference between low birth weight, or those infants less than 2.5 kilos, which were previously preterm infants, and then those who were truly born preterm. Dr. Apgar during this time additionally proposed that, hey, someone else should probably be in the delivery room, able to resuscitate the infant. And so that's kind of how neonatology was actually born. Then in 1970, it was actually 1963, neonatology got a lot of press, and we really began to recognize the need for respiratory support and understand the role of surfactant. And in the United States, a lot of this was driven by John F. Kennedy, who was a president of the United States. He actually had an infant who was born at 35 weeks and died of respiratory distress. So anytime you have a politician who has money, they tend to push the press towards that problem. And so there was a lot of funding push towards surfactant and recognizing treatments for respiratory distress. So in the 1970s and 1980s, actually, perinatal steroids were started being used for lung maturation. In 1989, surfactant became available in the United States. And we really started to focus on this, which changed kind of that landscape of who we can provide care to in the 2000s. And it's hard to believe that that was 25 years ago now, but here we are, right? We're focusing now on even different organ systems, the brain, other than just the lungs, right? And the kidneys are one of those. So we know that prematurity and low birth weight predispose the infant towards acute kidney injury, and they often come to us. They receive nephrotoxic medications. They may or may not have infections, hemodynamic changes, and the goal is to provide optimal nutrition, right? But we're suboptimal compared to the mom and the placenta. So all of that can lead to reduced nephron numbers, and you're going to hear more about that in Dr. Eskenazi's talk. But just to kind of give you a background as we head into potential treatment options. So this can lead to hyperfiltration, glomerular hypertension, proteinuria, systemic hypertension, further nephron loss, which predisposes these infants to chronic kidney disease later in life. But it's not just preterm infants and low birth weight infants who are at risk for this, right? So we have those with neonatal encephalopathy or HIE, where there's perinatal asphyxia involved. And I've actually had a few of these infants go on to require kidney transplants later in life because their kidneys take a hit too. And it's also well studied in the cardiac population that these infants are at risk for acute kidney injury as well as progression to chronic kidney disease, not just those that are born preterm and low birth weight. So the goal of this kind of whole series is to understand acute kidney injury, fluid overload, to take that toolbox and really expand it. And so hopefully the Davids will additionally help you with that. But we're going to focus mainly on dialysis today. So when I think about dialysis, it's important that we're all on the same page. Nephrologists love their acronyms. So there's a lot of acronyms out there, and it's really important to understand what each of those stand for because they are different, right? So there are different modalities within dialysis, and then there is also acronyms related to the duration of which that prescription is provided over. So we're going to go through the modalities first. So SCUF is slow continuous ultrafiltration. And when we talk about SCUF, what we're really talking about is water removal. Now with that water removal, you do get salt loss, right? Water follows salt. But really what we're talking about is like the fluid overloaded baby who may not need clearance, but is very puffy and needs that help with water removal. So SCUF is often what's used in that kind of option. Then we get into the clearance modalities, CVVH or continuous veno-venous hemofiltration. That is like coffee. What do I mean? I'll show you some schematics here in a minute. But what that means, right, is that you have, if you think of the blood as the coffee beans, your filter in your coffee machine is truly the filter of the dialysis machine. And the water that you put with coffee, right, is kind of your dialysate fluid or your replacement fluid. In CVVH, you put the beans and the water together. And that is true. You put the replacement fluid and the blood together and then shove them across the filter. That differs from CVVHD, or continuous veno-venous hemodialysis, which is more like tea. The water's on the outside of the filter, then you have the filter, and then you have the tea or the blood on the inside of the filter, and you get movement across that semi-permeable membrane. And then you have CVVHDF, which honestly is like the kitchen sink. It's just everything. You're doing CVVH and CVVHD. And so you're really getting lots of clearance with that. When it comes to duration, there is continuous, and you might see this abbreviated CKRT, CRRT, CKSD. It's all over the place, and probably is all over the place in my slides too, because various places want you to use various things. So I did that just to confuse you all. No, I'm kidding. But usually that's over more than 16 to 18 hours. Most devices can go out to 72. That will be important though when we talk about Carpediem because it can only go to 24. Then there's something called PERT or SLED. So PERT stands for prolonged intermittent renal replacement therapy. SLED stands for slow, low efficiency dialysis. And what they're trying to do is take whatever that baby would see in 24 hours or however much time, however often they're going to do it, and they're trying to compress it and pull it all off or clear all of it in an abbreviated time or 6 to 9 hours. Then you have intermittent hemodialysis, which is the same process, but that's over even a smaller time, 3 hours. And that's why I don't tend to talk about intermittent hemodialysis. At some places, it's the only possibility, but it creates huge hemodynamic shifts. So a lot of people have moved away from that. And then, of course, there is PD. And peritoneal dialysis can be kind of this continuous intermittent process through the peritoneum. It uses the peritoneum as a filter. All right, so let's talk a little bit about the difference between CVVH and CVVHD for those of you who are visual learners. And this was all not done by me. I do not have the bandwidth to create the movement of all of these small molecules. So I thank Jolene for letting me borrow some of these slides to use. So when we talk about CVVH, it is like your coffee. You're gonna put your blood through the filter. You're also putting your fluid with your blood. And then what happens is you pull that off and you're gonna get movement of all of those molecules across that pore, which are these kind of, let's see if I can find my pointer here. These are pointer, all of these. So this is your filter fibers here, right? So you have your blood coming through the filter fiber and you get movement of these molecules across all of these pore sizes. This is different than that CVVHD, which is that movement across the semipermeable membrane from an area of high concentration in your blood to an area of low concentration. In theory, it can also go backwards, but your dialysis solution does not mix with your blood. And it's actually really good for small solute clearance. So this is what this looks like. You have dialysate fluid that comes in here and moves down. This is a counter current mechanism. There are some that go concurrent, which mean your blood and your dialysate flow the same way. That is more in depth than what you need to know, but in general. And then your blood comes through it, and then you move those molecules across that semi-permeable membrane from an area of high concentration to low concentration, and your water typically follows that. Now, membrane, oh, that got cut off. Sorry about that. Membrane selectivity and the difference in filters often varies on the pore size. And then how you prescribe it varies how you want to clear it. So if you're thinking about diffusion or CVVHD, they both start with D, right? Small solute, so urea, glucose, creatinine. The thing to remember, especially for those of us who really focus on nutrition, is you're going to clear some vitamins in there as well. Convection is really good for some of the larger molecules. So a lot of times we think about this with sepsis. We as neonatologists don't think about it in rhabdo because I can't say I've ever seen a neonate in rhabdo, but they tend to think about that in your pediatric population. The thing to know though is all of the filters are designed so that albumin doesn't cross these pores and IgG doesn't cross those pores either. When we look at the different types of renal replacement therapy, you have your PD here. So this is a manual PD set, meaning you're going to start with smaller volumes. You can kind of control that volume. And then once you get up to a full fill volume, you can put them on what's called a cycler. And so then it's automated, the fill and drain. This white device is a picture of what an intermittent hemodialysis device would look like. This is the old, Baxter has a new name now, and forgive me, it starts with a V, and I can't remember what they've rebranded themselves to, but this is the Prisma Flex. They now make the Prismax, which is like a fancier iPad version. You have the Carpediem, which always reminds me of a mannequin. And then you have the Aqueduct's Smart Flow System. And these are kind of going to be the three that we focus on from a CRRT perspective today. But let's start with PD because it's a little different. So a lot of the knowledge that we have from PD comes, especially in infants and neonates, comes actually from the cardiology group. They were really the first to think about this, and this was true kind of in some of the adults too. So what they noticed is that AKI was common following cardiac surgery. And when they provided intraoperative ultrafiltration, they actually decreased pro-inflammatory cytokines. So this really got a lot of people thinking. Additionally, these babies had fluid resuscitation, vasoactive medications that were used postoperatively, but they also had fluid overload, which worsened their OI. They had increased duration of mechanical ventilation and prolonged hospital stay. So there were a lot of questions about, can they use PD? And PD catheter placement and dialysis are generally safe, and there is a low rate of complications in the pediatric literature. And we're thinking maybe we can get a benefit of increased clearance of pro-inflammatory cytokines as well. So this started some of the studies related to PD in the neonatal cardiac population. And I always butcher the other David's name, Kwiatkowski. So he first started, and this isn't the picture of that publication, but he first started with the retrospective matched cohort, where he looked at just placement of PD catheters. And what he found was that there was a shorter time to negative fluid balance when they did it in the high-risk population post-cardiac surgery. And so then they did this randomized control trial where they looked at placing a PD catheter versus using Lasix in those patients who were under 6 months, who were peeing less than 1 ml per kilo per hour out of urine in that first 24 hours post-op. And what they found is that those that were randomized to furosemide were 3 times more likely to develop fluid overload and 3 times more likely to have prolonged mechanical ventilation. Now, it didn't carry all the way out to ICU length of stay, but for those of us who work in the NICU, that surprises no one, because if you're less than 6 months, there are many other things that often keep you in our NICUs or even in the CICUs when you are that small. Now, when we think about the challenges and the advantages to peritoneal dialysis, the challenges, this is true when I show all of these slides, the challenges are going to be on left and the advantages are going to be on right. For PD, some of the issues that we face is that there's decreased clearance and filtration rates. We can't really predict what that is going to do, what that area is going to do, right? Additionally, there are lots of mechanical complications, especially in babies where the abdominal real estate can be very small. It depends on their skin integrity. So you can have a lot of leak, you can have catheter displacement and obstruction. And so those are common things we see in our neonates, especially our preterm neonates. You are putting a dextrose containing solution into that abdomen to try and get the water to come out. And so that increases your risk for peritonitis as well as other infectious complications. But advantage-wise, the therapy can be continued outside of the hospital. So it's great for babies that are going to require this as a long-term option. And additionally, it doesn't require anticoagulation, right? So for some of our babies, it's ideal. However, many of our infants in the NICU have all sorts of abdominal pathology that doesn't allow us to do PD, right? So here's great picture, free air, you got a football sign, this isn't good. And if the, my surgeon takes them to the OR and opens this abdomen and sees neck, they're gonna be like, yeah, joke's on you, no way I'm putting in a PD catheter. And so it really makes us really have to consider what are our options out there. So this is where CRRT can play a role. But what do we know about continuous renal replacement therapy in small children, small infants, and neonates? This was a study published by Dr. Ashkenazi in 2013. So if you want to know specifics, great to hound him on him and see how his memory still goes. But they analyzed data from 84 children who weighed less than 10 kilos from the prospective pediatric CRRT cohort. Their median weight for this study was around 4.4 kilos, but it did go as small as 1.3 kilos. And the average time on CRRT or to start of CRRT was around 70 days when they put them on. When we look at survival of this cohort, it's not great. So when you're looking at the less than 10 kilos versus the greater than 10 kilos, those less than 10 kilos at the time of CRRT start had a really significant mortality difference of just greater than 40% compared to the bigger children, which were greater than 60%. They then broke that down into less than 5 kilos versus 5 to 10. And interestingly, they didn't see a difference. But it really got a lot of people thinking, why is their survival so starkly different in these two populations? So they looked at survival and what survival increased with. And they found that those that were able to achieve their dry weight, those that had urine output at CRRT start, those that had a lower percent fluid overload compared to greater than 20%, and not shockingly, those with lower mean airway pressures, right? If you're trying to lift all of that fluid, you're going to need a higher mean airway pressure. So all of these things all pretty much go together with a lower percent fluid overload. But when they were really thinking about how can they make a difference, they started to think about the size of these infants. So 4.4 was their median weight. And if you take a 4 kilo kid, which is honestly big for some of our units, and you look at their total blood volume, they estimate about 80%, right? So 80% times 4 kilos, you get about 320 mLs. Well, in 2004, which is what that study kind of goes back to, they were using the PrismaFlex M60 primarily. Now, the M60 filter at that time with all of the tubing had a priming volume of 100 mLs. That meant that if you put an infant that was about 4 kilos on that circuit, at any given time, they had about a third of their blood volume outside of their body. So additionally, you had to prime that circuit with lots of blood. So this kind of led a lot of people to really start thinking about this. So in the first picture in 2012, you have Claudio Ronco, who's in the back, who's an adult nephrologist and is a good friend of Dr. Stuart Goldstein, who's at Cincinnati Children's and was my mentor. And the front forward of him is Dr. Zachariah Ricci, who is now a pediatric intensivist in Florence, Italy. He was a fellow at the time working with Dr. Ronco, and they developed Carpediem with 3 different filter sizes that range from 25 to 41 mLs. About the same time, the UK was looking into this as well. So in the United Kingdom, they were using syringe-based systems, which led them to develop the NIDIS, or Newcastle Infant Dialysis and Ultrafiltration System, which actually has an extracorporeal circuit that can go even less than 10 mLs, but at the first one, I think it was around 13 mLs. And they started using that just in the United Kingdom only. And that's the only place that I am still aware that it is being used. We lagged behind in the US getting FDA approval for Carpediem. And so people started modifying adult platforms to try and help babies and infants. And so the one that they first started to modify was the Aqueduct SmartFlow system. And the reason they chose this one, it's actually an adult device. It is designed for congestive heart failure. And in theory, in an adult, you could put it and hook it up to an IV, but it only does scuff. So it only does water removal. But it has a small extracorporeal volume of only 33 mLs. So they said, well, CVVH is just adding some fluids to try and help the blood and push it across the membrane. So if we give them pre-filter or honestly post-filter replacement fluids, we can modify it into what we call now modified aqua or CVVH. And so a lot of the US sites started doing this. In 2019, everybody suffered from COVID, and the NIH put a lot of funds towards COVID, and there was a lot of kidney disease that came with it, especially in pediatrics as well. So the PrismaFlex had an HF20 filter developed with it, which had a much smaller priming volume of only 58 mLs. And I say that it was designed for the PrismaFlex, but if anybody's ever used it with the PrismaFlex, like walked in one time and they had like duct taped it to the side. I think it's actually designed for the newer model, the Prismax. And I hear it goes much better with that, but there were people using it and it was working at least well. And then in 2020, the US got approval for Carpediem, and we were the first site at Cincinnati to use it. Cincinnati, Seattle, and then Texas as well were the kind of the first 3 centers to put patients on. But we had learned a little bit from aqueducts and using aqueducts across the US, and we used it as well at Cincinnati before we had Carpediem. So this paper was published by Dr. Minin looking at the use of it across the US. It was retrospective. It had 119 children. There were 72 of those children, though, that were less than 10 kilos, and 66% were less than 30 days. Most were fluid overload and AKI, but they did have some babies with end-stage kidney disease or congenital kidney failure. And what they found is that they had a 60% survival to the end of CKRT, but only 32% survived to hospital discharge. So we still weren't making much progress when it came to survival, but we were learning a lot. There is a more contemporary study published out there for those of you who are a part of WeRock. It does involve 32 centers across 72 countries, and Australia is a part of that. They have published a paper, again, looking at less than 10 kilos, but with an updated cohort. This cohort does not include Carpediem. It also does not include those with congenital kidney failure. It is mainly those with fluid overload and AKI. They went down to 1.9 kilograms. And they were much earlier to go on and had a much shorter stay than the PPCRRT cohort. But they saw 54% survival to ICU discharge, so improved from that initial US aqueducts cohort, which is good. So when we talk about the adapted CKRT or CRRT or KST, whatever acronym you want to use, platforms, and think about the challenges on the left versus the advantages on the right. Well, one, if you have it available, it's what you have available. But challenge-wise, It can have poor ultrafiltration accuracy, which may lead to fluid retention or fluid losses. And some of that is because it's designed for an adult or a larger kid, which may be able to tolerate a much larger error rate. Additionally, because they often require higher blood flow, they then need larger bore catheters to really be able to make those machines work. They are also designed for adults who don't get as cold as babies do, as quickly as babies do. And this is always a really important thing, regardless of which CRT platform you use to think about, because as neonatologists, we are very used to our babies cooling from the outside in. But in CRT, since you're returning blood, even if you warm it, right, they're cooling from the inside out. And so often my nurses are like, well, the skin temperature is normal. And I'm like, yeah, but you're bradycardic and you're hypotensive. So can we put that warmer? And so it's a frame shift for many of our providers and our nurses. But with the bigger devices too, you have more exposure over time to the room environment. And so there is a higher risk of low body temperature. However, compared to PD, the therapy does allow for higher clearance and more precise UF, right? And then you can get dynamic changes in fluid removal. So you can kind of control that if your patient suddenly changes. Maybe you were really sick and you just wanted to pull off what you were giving, but you wanted to leave all these fluid boluses on, and you can do that. Or now they're better and now you want to be a little bit more aggressive and start to remove more fluid because they're fluid overloaded, but their blood pressures are stable. So it allows us to adjust on the other end. Because of that, we can get steady dosing of medication and kind of predict it a little bit better than what we would get with PD. Let's hop back though to dedicated dialysis devices for neonates, right? So I'm mainly going to focus on Carpediem. So Carpediem 2012 was the first neonatal and infant dialysis device designed in the world. And Dr. Claudio Ronco published the book that's on the far right. It is available in Italian and English, and it kind of goes back and forth on his story and the child's story. It's a very sweet book. It is not as detailed. So if you're like a bioengineer, I once thought this would be great for a bioengineering class to read, and they were not interested. It's a little more touchy-feely, but it is good. So Carpediem, it is designed really for patients weighing 2.5 to 10 kilos. That is what it is approved for in the US as well. However, many of us practice outside what the US regulations are. And I'll talk a little bit about the lowest number that we've seen. It can provide hemodialysis or CVVHD and hemofiltration or CVVH therapy. It has the small extracorporeal volume, and then it has micronized pumps to really detect pressure changes, and then calibrated scales to the precision of 1 gram. So a very safe device when you think about air. The first patient that went on was a 2.9 kilo infant with a subgaleal hemorrhage and subsequent hypovolemic shock that received ultrafiltration for 63% fluid overload. She was cannulated with actually a 4 French dual lumen catheter, which is much smaller than we typically use for some of the adult or modified devices. And she was started on CVVHD. They, at that time, weighed the ultrafiltration bags to make sure the error was what it was reported because she was the first patient on. During her time on CRRT, she had hyperbilirubinemia, so she did have to come off occasionally for single pass albumin dialysis and plasma exchange. But ultimately, CRRT was discontinued on day 25, and she was discharged from the NICU and ultimately home. She still did have clinically significant chronic kidney disease at the time of discharge. However, without Carpediem, her prognosis would have been very, very poor because she had contraindications to peritoneal dialysis, and they weren't able to obtain vascular access that was compatible with some of their larger devices to get those machines to run. So really a cool story. When we look at the survival of infants treated with Carpediem, comparing that PPCRRT cohort to the Carpediem Italian registry, which is the one, there's actually a French and Italian registry that is published right now. You can see that the indications are fairly similar, even though the cohorts are over 10 years apart. The big one that's different in the PPCRRT is that you had some hepatic indications, which we didn't see in Carpediem. And some of that probably has to do with the fact that Carpediem cannot do CVVHDF, but you see this increase in renal as well. When it came to survival, there was an improvement in survival to CKRT discontinuation. So they survived to their last treatment course with 97%, but only for 50% survived to ICU discharge. So again, we're really struggling with getting them all the way out the door eventually. And this has to do with the Italian cohort. Our current paper for the US is under review right now. When it comes to the different filter options, there are 3. There are only 2 that are available in the US, but there is a smaller available filter available in Europe, which is the 26 priming volume filter. The one thing to point out with Carpediem is that it has a maximum time of 24 hours of use. So it's not necessarily related to the filter so much as it is related to the actual device. The device will only give 24 hours of therapy. Now, if you pause the device for 2 hours, it will still deliver 24 hours. So you'll run for 26, but it has a maximum duration of 24 hours, which is different than most CRT devices. The other difference is it only has 1 bag available for dialysis solution or replacement fluid. So it's a 2-liter double chambered bag. It does have a 24-hour expiration once that chamber is mixed. You often go through multiple bags in a treatment period. And there's only 1 commercial composition available, which is really important to know when you're thinking about nutritional deliveries and what you're going to equilibrate to. So sodium and potassium can be added to this bag because it is compatible. It has a 2.5 sodium in here, but phos cannot be added to this bag. And I say cannot because there really hasn't been safety testing to make sure that it is safe to add to the bag. And that's because the bag contains calcium. So there's a lot of concerns about it precipitating out. When it comes to infant-specific CKST, CRT, there are a few things. This doesn't really include nidus, but you can kind of think about it in that way too. It's mainly focused on Carpediem. But challenges-wise, it may have limited utility in treating patients requiring high clearance because it cannot do CVV-HDF. That is true for nidus too, which we'll talk about in a minute. And because they're newer devices, we have either a lack of availability or a lack of expertise, right? We're still all figuring out how to learn this device, even 5 years later. But the benefits are that it has a small circuit volume, so it often doesn't require blood primes, so less blood exposure. And the therapy offers improved precision and UF accuracy because it's designed for neonates. So when we look at the characteristics of all of the devices, you have Carpediem here, Aqueducts, nidus, and HF20, which are the most commonly used in infants and neonates. I've tried to highlight some of the differences here. So for the top parts are mainly related to prescription, which nephrology should be providing. But when we think about it from a neonatology perspective, Carpediem is one that only prescribes in 24-hour increments. For me, it's super easy. I think about total fluid goals, right? So I'm thinking about 24-hour increments anyways. For my nephrology colleagues, it's a little bit more challenging because they're used to thinking in hourly. Precision of fluid removal. The other ones are designed more for small children and neonates. Aqueducts, you are modifying an adult device. So you are at that risk of your Alaris. Most of us use the Alaris pump, which is a 10% error. So you can deliver 10% more or 10% less, and that it doesn't often alarm until 100 ml difference. Modality-wise, again, you see that Carpediem does CVVHD and so does nidus. Aqueducts does not. Nidus does not do CVVH, whereas Carpediem and Aqueducts do. But HF20 is the only one that does CVVHDF. Through all of this, though, the other thing we really learned is that we see a new population really utilizing these devices, and that's those with severe congenital anomalies of the kidney and urinary tract that also have congenital kidney failure. So those with oligo or anhydramnios at the time of birth. The goal is that you're ultimately going to need a PD for chronic therapy, but you can provide fluid homeostasis while that PD site is healing and potentially increase their nutritional delivery, which will allow that site to heal a little bit better. So historically, we often handed these babies their moms to die and provided comfort care. But now what we're seeing is they're going on to thrive and get kidney transplants and do great things. Now, some of this also is not just related to dialysis, but a little bit about fetal therapies in the US and in other places. So in 2003, that says systemic, there was a systematic review that bladder drainage may improve outcomes. And this was off this estimated probability of improvement in pulmonary hypoplasia. So the US really took this and ran with it, which I didn't actually know that the UK had an entirely different opinion, which is very interesting. But the Pluto study looked at vesicoamniotic shunting, or diverting the urine from the bladder for bladder outlet obstruction into the amniotic sac. And they saw this improvement in theoretical improvement in pulmonary hypoplasia. So a lot of people ran with this. And then in the US, we started doing amnio infusions, in which you instill normal saline or lactated ringers or something into the amniotic space in hopes that you, one, increase that pressure gradient to promote lung development, and then also provide that infant a little bit of cushion to prolong gestation. Nationally, the RAFT trial is still evaluating serial amnio infusions. You can do both direct or needle straight in, but there are some places that are doing port placements. So they have a port that goes down into it, and then they infuse that into the port. Historically, they were doing BRA. That recently stopped. I don't know of any sites doing BRA both in the RAFT or practicing outside of the RAFT, but it has changed the landscape on who we provide care to within the US. So with all of this, we said, okay, those babies are going to be very different from our AKI, fluid overload, sepsis kids. And now we have this new device as well. And we really need to get together and talk about how to provide the best care. So in Cincinnati, when we got Carpediem, we were already using Aqueducts for some of the severe congenital anomalies of the kidney and urinary tract. And we said, let's create a learning health network. So improving CRRT outcomes in neonates and infants through interdisciplinary collaboration. We are separate from WeRock in the fact that we really wanted to focus specifically on neonatal and infant dialysis devices. So the goal was to develop a multi-center quality collaborative network to share best practices, treatment hurdles we meet every other month, and quality metrics for those less than 10 kilos. We'd also assess for predictors within patient level data, prescription data for CRRT filter life, or like a union. We can also go to the companies and say, we need this, and then describe patient survival and renal recovery, as well as describing indications and use across multiple institutions. Because we recognize that one of us may see one infant, and that one infant, nobody publishes case studies anymore, right? But somebody in Seattle may benefit from that in the future. And that has very much happened within our group. We are often talking about our failures, not necessarily our success stories, but we have learned a lot from each other. We have multiple sites across the US. We do have international sites too. No one internationally is entering data yet because there is such discrepancies in what is offered at every place. So we're really focused on the US data to start. But we are, if they can get their agreements through, we are more than happy to put it in. We are interdisciplinary. So what does that mean? We have representation from physicians, nursing who join the calls, pharmacists, dietitians. We even have a librarian who occasionally joins, and we have a wide variety of who joins: nephrologists, neonatologists, critical care physicians, even an OBGYN who comes. Additionally, we have bioinformatics support to help us build a dashboard. So every site gets their own dashboard. They can visualize their data, and then they can compare it to the overall collaborative data, both filter life and survival. And our main SMART aims when we think about QI, right, is maintaining filter life, because that means that we know that we're delivering the prescription that or the filter that we prescribed. It is important, though, when you're thinking about CRRT, to think about those key drivers, right? Because that's going to be the main things that you need to focus on when you're delivering this therapy or when you're thinking about patients. So anticoagulation can impact it. Vascular access can impact it. Prescription, how you write it, can impact it. Alarm mitigation, huge push on both of a nursing education piece, because the faster you can address that alarm, you can get that device back up and running, and the less likely you are to lose your circuit. And then initiation timing. When do we go on? We knew from the PPCRRT study, the earlier we went on, the more likely they were to have good outcomes. When we look at our QI data, so this is a run chart looking at planned survival of the filter to planned treatment end. We see that we've held pretty steady at about 70% as new sites join, which is good because there's still a lot of sites that are just now getting their devices and trying to figure out how to do this. But the other piece that I always think it's kind of weird to plot this on a QI graph, but is patient survival. Now, I'm not saying as a group we're responsible for increasing patient survival, but I do think it's helpful to think about the fact that we get together as a group every month and talk about these babies and talk about what we've seen and how we can provide better care. So what we've seen is this gradual increase. In 2020, we only had 5 patients because we started really late. That was the year it got approved. But in 2022, we had, or 2021, excuse me, we had 22 patients, which was a good cohort. And we started at about the same risk of survival to ICU discharge. This is true for hospital discharge too. They are actually the same in our data, which is interesting. But we started about the same as PPCRT, but we've slowly increased that survival rate. And even if you add these 7 that are incomplete in 2023, it still puts us above the 60% line. So we are really happy with that. We will see where 2024 leads us, and we continue to have new sites added every day. Now, thinking about CRRT and the role of the neonatologist, how can we advocate for our patients? Well, interestingly, when you look at unit use of Carpediem, so this is the first 11 sites, actually 13 sites, we surveyed them when they first got Carpediem, and we said, where do you use CRRT in your hospital? And everybody said, oh, we definitely use it in the PICU. We pretty much all use it in the CICU, but we don't really use it in the NICU. However, when they went live with Carpediem, what we saw is a huge shift in who used it in the NICU. And so a lot of people were now using a CRRT device in their NICU. And so we really wanted to support them through this because we were learning as well. But it really depends on how your site is set up, what your structure is, and what your education is. So there are different types of models when you're giving CRRT or delivering this therapy. There's a collaborative model, which is a partnership between 2 departments. So maybe the ICU nurse takes care of the baby after you initiate and every day to day, but she still manages alarms, but nephrology or ECMO team or somebody else comes in and starts it and takes them off. So that's kind of an example of a collaborative model. There's the critical care nursing model, which critical care provides everything. Nephrology is out seeing patients in the ether and an outpatient, and they don't ever see these babies. You can call them and ask them maybe a question if you need to, but it is primarily done by the critical care team or solely done by the critical care team. Then there's nephrology-based nursing model too, where nephrology provides all of the care surrounding the dialysis device. Those tend to only be nursing models because you still have critical care management of the babies. And I haven't met a nephrologist who is comfortable enough, who isn't dually trained, to do that yet. But when we surveyed sites, what we found is most people were leaning towards a collaborative model. However, there are a few centers that expect their neos to write the prescription and their nurses to completely take care of the babies. And that is really interesting too, as we think about training our fellows and all of our trainees who may go to these institutions and be required to provide this care. So it does differ a little bit between the models, right? But the role of the neonatologist is also very similar in both models. We need to recognize who will benefit from the therapy, but also recognize the limitations. Just because we can doesn't always mean we should. We are responsible for providing really good nutrition and trying to get them to grow. We are responsible for their critical care. What kind of vasopressor support should we use? If you call a nephrologist in the middle of the night and ask them about vasopressors, which I've had fellows do before, they're gonna call me or call you, right? Fluid balance, thinking about it, not just growth, but is this water weight? Are we overloaded today? Are we a little on the drier side? What does this look like? Is the weight up water, or is it actually growth? Because we're providing good nutrition now. But then in the critical care model, you're going to also have that prescription and anticoagulation piece. So at your institution, if you were providing CRRT in your NICU, it's really important to understand how your roles are set up. Now, when we think specifically about recognition, it's expanding that toolbox, AKI, fluid overload. That's what Dr. Askenazi and Dr. Selesky are going to talk to you about. And then in collaborative models, it's always important thinking about that PPCRT trial. If you have a collaborative model, to call nephrology early, right? The earlier you go on for CRT, the more likely you are to have a better outcome. And then the necessary steps. What do you need to get that baby on if you're thinking about doing it? Who's going to place your line? Organizing the team, the nursing, the dietitians, the pharmacists, consulting physicians. What does that look like at every institution is different. And the most important piece, regardless of what it looks like, though, is communication, right? Because a breakdown in communication leads to bad outcomes. Now, vascular access is a key aspect of successful CRRT therapy, and so it deserves its own slide because it impacts the adequacy of treatment and your filter life, and also staff satisfaction, because if your nurse isn't happy, she's going to call you all night long. There are different types of lines. There are permanent lines, which are often called tunneled lines, and then there are temporary lines, which are called non-tunneled lines. There are some published guidelines out there related to catheter size, but every institution honestly has slightly different ones. So at Cincinnati, for less than 10 kilos, we used a 6 French power pick because they're stiffer, and we cut it down to the size. They actually went away from that though, and they've started using more double lumen 7 French, their glide paths that go in and they're tunneled for the end-stage kidney disease because they require them for a long time. At IU, we use all the way down to 5 French power picks, and we cut them and then have our IR place them under fluoro. But with vascular access, right, there's limitations to infant size and skin integrity, especially when it comes to catheter placement, both hemodialysis catheter as well as PD catheter. Then you have to think about short-term versus long-term need. Is this a bridge to a long-term therapy? Are you expecting this infant to be on for a long period of time? And pulmonary survivorship, what does that look like? And what does your institution offer? Because this is different at every place. Who does the prenatal counseling? Do you discuss this? Do you discuss the risk of AKI and even just your preterm infants? Postnatal, if you're going to offer this therapy, do you have a weight cutoff? What are you comfortable with providing at your institution? And then in the US, we have some places that will offer ECMO for those while they're determining whether or not they're going to be a pulmonary survivor when we're specifically talking about the congenital kidney failure. Many places do not, but some places do. All right, so the other question I often get is how low do you go? So Dr. Sutherland, who is out of California, put together a paper where he reported 7 neonates, 6 of them with congenital kidney failure, but 1 with renal failure from twin-to-twin transfusion. They went all the way down to a 3 French power pick cut to a length, and they would use the right femoral, the IJ, all over. As you can see, they had a median gestational age of 32 weeks, so still very preterm. A median birth weight of 1.5, with the lowest being 1.2. But the weighted initiation, the lowest was 1.5. And that is what we are pretty much seeing across the board in the US. Most places don't really go much smaller than 1.5. Every now and then, I think I've heard of 1 or 2 1.3 infants who have gone on and had successful runs on CRRT. But the thing that I think is important to take home from this is that when you look at their respiratory support at 1 week, only 1 required mechanical ventilation. So I think even with this population, it was very self-selected for those who were going to be pulmonary survivors and kind of describes their level of critical illness at 1 week of life. The other thing that we need to think about, again, is growth in nutrition and what does this look like? Some places are comfortable with enteral feeding on CRRT and others are not. So are you prescribing enteral feeds or TPN, and what does that look like and how does it interact with your HBio bag, right? Because you have calcium. Interestingly, you have a high bicarb content, which is really good for your AKI and fluid overload babies that are acidotic. Not so great for your congenital kidney failure kids who don't need this. Potassium is only 2.5. Do you need to add K to the bag? And also you're dialyzing against a FOS of 0. So if you are doing CVVHD in these infants, many times they require a lot of FOS to keep their ATP happy. Are you accounting for insensible losses? These devices, specifically Carpediem, is very precise. If you tell it you want to remove 100 mLs, it will remove 100 mLs, but if your baby is also losing 50 mLs in insensible losses, you have to think about that ahead of time because Carpediem won't recognize that. Aqueducts, this is some of the benefit of Aqueducts. It does come with a crit sensor, so you can see how fast you are hemoconcentrating your baby, and you can set alarms based on the crit sensor. So this is why some places have actually not moved to Carpediem because they really like this feature on the Aqueducts. Then we have to think about fluid balance and growth, right? Is it water or is it fat? Sometimes it can be a little difficult to tell, especially when edema doesn't show up until you're about 30% fluid overloaded. Now, we did look at growth overall in our infants who require dialysis versus no dialysis. Interestingly, our hypothesis was actually opposite. We thought, oh, we're probably dialyzing lots of nutrients off and we're really worried their growth is going to be horrible. And so we looked at this in our end-stage kidney disease cohort. And now weight z-scores, you kind of have to think about a little bit and take with a grain of salt, right? Because those are going to be impacted by fluid balance. But what you see is that you get this improved catch-up growth in those that receive dialysis. This is birth, and this is all the way out to 9 months, compared to those that have no dialysis or didn't require, who should be less sick. This holds true for their length scores and their OFC scores. So you can see these are Z scores here, corrected for sex and gestational age, 0, and then you kind of get catch-up growth. Whereas the no dialysis, they start a little bit smaller, but then they stay low, especially in length. So it was really interesting. We haven't further studied this, but there's been lots of questions. Is it because we have improved nutritional follow-up for those that are in dialysis? They're often coming back to the clinic more, so we're checking weights on them. We're really trying to maximize their growth. Or is there some removal of other mediators that impact growth? We don't really know yet. When we think about critical care vasopressors, this really relies on us, right? The pathophysiology of the underlying disease and what should we use. But we also have to think about those other things with CRRT. Are we cold? Because that will cause us to become hypotensive. If you are doing a blood prime or you are using citrate as an anticoagulant, you can lower your calcium levels. So what is your iCal telling you? Are you being too aggressive with your fluid removal and you're causing hypotension because you're not able to refill those capillary beds fast enough, right? And we have consequences of anticoagulation too. Is there a bleed somewhere that we're missing? But altogether, panic causes tunnel vision. So the best thing we can do is stay calm, right? Calm acceptance of the danger allows us to more easily assess the situation and see the different options. And anytime anybody starts this device, I can tell you the very first thing they want to do is blame the device. Oh, we started something new. That's it. That's what's the problem. But sometimes we have to just go back to the basics. And so most often it's actually not the device. And then with fluid balance, right? This really falls on us because we don't want to make them raisins, but we really don't want them to be fluid overloaded. So really assessing those babies every day. Do we think that it's water? Do we think we're providing adequate nutrition? And what does this look like? So when it comes to the role of the neonatologist, it can be very different based off of your model, especially when it comes to prescription and anticoagulation. But overall, it's pretty similar. And so it's really important to understand our responsibilities and how we can best effectively communicate with nephrology, especially when they're involved, because this is not an excuse, right? To next time I'll just read your mind. So in summary, know what options you have at your institution and what's near you. Know what options are out there. Can you refer locations, publications? Do you have CRRT? Understanding the models, the devices, the impact on the patients and limitations, because advocating requires knowledge. And this requires collaboration between basic scientists and the clinicians, but also most importantly, the patients and what they perceive their outcomes are, which outcomes are important to them. And so this is one of my lovely ones who have gone on to transplant, and she is doing great. She has had her 4th birthday and is just whip smart and schools me every time I see her. So thank you so much. Happy to take questions.
Thank you, Cara. That was a really great overview of a renal replacement therapy. So you brought us to the terminology, and there was lots of it. The physiology in physical and visual views, which was great, and then to all these different types, which I thought was really interesting to see with its advantages and disadvantages. You brought us a bit to the indications, and that the indications were shifting a little bit depending on what particularly your antenatal group is providing, which was really interesting to hear. And really, most importantly, if you try a new therapy, that collaborative approach into whether it is you're describing cases, you're right, we don't do case reports anymore, but if we do something new or something rare, we need to share it with each other, the good cases and the bad cases, just to get better in that particular aspect. So I thought that was really a wonderful overview. And we have time for a couple of questions. Anke Rijmakers. Anke, are you there? Just ask the questions you want to ask. Maybe she's not there, though.
Oh, here. Yeah, I'm here. Hi, Kurt, and thank you, Cara, for the excellent talk. It was really amazing. I hope you can hear me. I'm here with my team. I'm here with my team, all nephrologists or nephrology trainees, and our lovely clinical nurse consultant. I was wondering, so I was trained in Europe, and we did use Carpediem in Belgium, but yes, I'm not aware of any centers in Australia using neonatal CRRT devices in Australia. Are you aware of centers who are thinking about it, who want to implement it, or any strategies?
Yeah, good question. I have not, Allison Kent does, and I don't know if she's on here. She does a lot of work with the NKC as well, and Tom Forbes. And I know we've talked about it. The last time I talked to the international group with Mozark Medical was honestly probably a year ago, and I knew Australia didn't have a dedicated neonatal dialysis device yet. Now, whether or not you have centers who are using the HF20 filter, I am not aware of.
Look, it's a good point. And Cara, you brought it up as well. It's about the recognition of fluid overload and indications which are actually there, and which we probably need to work on first, and then we need to have the opportunity to have these treatments into place. And I'm really just like Anka. I hope that all our renal neonatologists, and I know at least 3 or 4 of them, are gonna jump up after these sessions and say, I think this is something to start up. So that's a great one. Look, there's no questions yet. Please type your questions in the chat box. You talked about the medications, and of course, medication is going to be filtered out. Can you tell us a bit about what effect, how much medications is filtered out? How much do I have to increase my vasopressors?
So a lot of what I tell my team, when I say we can kind of predict it, there's really still poor evidence out there, but it is an extracorporeal device, right? So anytime you are starting an extracorporeal device, whether it be ECMO, you are taking a blood that doesn't have any of that medication in it and putting it into the baby and pulling the blood out of the baby that does have the medication in it. So you change your volume of distribution. So adjusting volume of drugs that are impacted by volume of distribution is really important. It also depends on the filter and whether it's lipophilic, right, or hydrophilic, and how that's going to cross, to kind of think about some of those things. So our pharmacists are really looking into that. I have, in fact, there's a pharmacist out of Utah who actually, we have a biorepository within Iconic who's asked to look at some of these so he can do some PK predictions for us, which would be lovely. Because most of us are honestly just making it up right now, right? We're looking at volume of distribution and saying, okay, we think we're going to increase this much. Carpediem is specifically interesting for that too, because you're coming off of it every 24 hours. So every 24 hours, you're stopping the blood. And if you're not prime, like you can do circuit to circuit primes. So take that old blood and put it into the new circuit. But if you're starting over with a fresh circuit, you have to then, again, know that you're taking away blood that then has that medication in it. That's true for platelets. It's true for coagulation factors. And so I see this too with platelets. Oh my goodness, we're having lots of thrombocytopenia. Well, actually, we're probably having a bit of a delusional effect. There's probably a little bit going on, but we're giving them new blood every day that's just PRBCs. So taking some of that into consideration too.
All right. Does it filter out TPN?
So it'll filter out depending on the membrane selectivity. But again, most of those molecules, your vitamins, are going to be small molecules. So you are going to get clearance of some of those vitamins, which is less important for some of the acute ones where you're only going to do CRRT for a few days, but really important for those who have end-stage kidney disease and then require a prolonged duration of CRRT because you have some sort of PD catheter failure, right? So some of our kids have been on them for 4 to 6 months because we're trying to go back and forth with revisions on the PD catheter or get them large enough to go to an intermittent hemodialysis device. And so really being mindful of what's cleared and whether or not we should be providing more vitamins or minerals are going to be really important. Molly Vega is a dietitian out of Texas Children's who has done a lot of work with this, and she has some nutritional recommendations out there. As well as with AKI, there's been a pendulum swing. Like we used to restrict protein, and now everybody's like, no, give lots more protein. We need more protein when the kidney's injured. So we actually pushed to 4.5 for amino acids in our TPN when we're prescribing on CRRT.
So now, look, lots of things to learn, particularly for people who's going to start or in this therapy. I'm assuming they can reach out to you for collaboration.
Oh, absolutely.
And hear about it. You mentioned that one of the machines had like this continuous insensible loss monitor. Is that like a continuous weight measurement, or what is it?
It's actually a hematocrit sensor. So the Aqueduct comes with a hematocrit sensor so that you can see over time your concentration and how your blood is impacted. So if you have a truly fluid overloaded baby, honestly, you want kind of a flat line because you want to be pulling off and refilling. But what you'll see is over time as they get more and more hemoconcentrated as you remove more water. And so you can set a threshold to say, I don't want to turn my baby into a raisin, please stop it. At a certain, so a lot of people like that. The downside though is if you're bleeding and you're losing it, it doesn't necessarily alarm. And so there's this fear among many neonatologists, honestly, because it has a higher error rate and you have to have a lot more hands-on with nursing checking it because it's used to adults. If you and I lose 100 mLs of blood, it's not as much of a big deal. But if you have a 4-kilo infant who loses 100 mLs of blood and doesn't get it put back in, it can mean the difference between life and death. So.
From a nursing perspective, is this the same amount of nurse to patient ratio as, say, a patient on ECMO?
Yes. So it depends on the model. Most places that paper is actually in review. Some of our nurses and nurse practitioners wrote a paper on bedside staffing and what this looks like at some of the initial institutions. Most of them were kind of a 1-to-1 ratio or a 2-to-1 ratio for the bedside nurse. And then they had someone sit at the device continuously to make sure that there was alarm mitigation and alarms on. That is the same at IU. We actually use Aqueducts right now. And the nurses were trained before I came there. And so we have one person who sits device. The bedside nurse is also trained. So she can, when somebody needs to take lunch break or whatever, she can cover that device. So they are both trained, but someone specifically is primarily there for the baby and someone is specifically there to monitor the device.
Yeah, that makes sense. Okay, time for a last question from the audience here. Dr. Anggrani from Indonesia asked, they only have Prismaflex. What do they need to then start doing CRRT in neonates?
So if you have Prismaflex, using the HF20 is probably your best bet. And that's probably because it has a 58 ml volume. So you're lowering the need for extracorporeal blood. Most of your infants are still going to require it at that point, right? But for the most part, it's fairly safe. Now, I don't know if Dr. Goldstein, they were doing the HF20 study when I was in Cincinnati and reporting on it, and I haven't seen that published yet. I believe it was included in WeRock though, but it is fairly safe and we use it a lot. Actually, both centers that I've worked at have sent any of our inborn errors of metabolism, because you need the CVVHDF for clearance, up to the PICU to get the HF20. And so it's all of those babies who have gone on it who had survivable hyperammonemia have done really well on that device.
All right. Well, thank you so much. And thank you so much for staying up late. Unite.
Oh, of course.
This is a fantastic first in a series about 3. Next week and the week thereafter, we're going to have another 2 talks about renal in neonatology. Dr. Askanowski is going to talk about the oliguric baby. So thank you all for attending. Thank you, Cara, for talking, and I hope to see you all next week. Thank you.
Wonderful. Please feel free to email me if you need anything.
Thank you.
Lovely to meet you all.
Recording stop.